It's my pleasure to discuss with you the problem of hypertension, which is considered an important national and international medical dilemma. Hypertension is associated with high incidence of cardiovascular mortality and morbidity. This is because hypertension is usually asymptomatic, and also it is difficult to diagnose and to treat. Normal blood pressure is 120/80 or less. Hypertension is defined as persistent elevation of systolic blood pressure of 140 millimeter mercury or more and diastolic blood pressure of 90 or more. Nearly 95% of cases are classified as primary hypertension with unknown cause, while only 5% were considered secondary to identifiable causes and is called secondary hypertension. Epidemiological studies showed that hypertension affects more than 1 billion individuals all over the world. Also, hypertension is a major national health problem in Egypt. Nearly 20% of Egyptians have hypertension, and 50% of elderly people above the age of 60 have hypertension. Because hypertension is asymptomatic, about 38% of hypertensive patients are aware that they are hypertensive, and only 24% of them receive treatment. And unfortunately, only 8% who are controlled and reach the target blood pressure. Hypertension is called the silent killer because, as I just said, 92% of hypertensive patients are either unaware or uncontrolled, and therefore vulnerable for serious cardiovascular complications. Several epidemiological studies reported that hypertension is a leading cause of mortality all over the world. It is more lethal than tobacco smoking, than diabetes, than physical inactivity, than obesity, and other many risk factors. The European Society of Cardiology Guidelines in 1918 reported a close relationship between systolic blood pressure and mortality and disability. In this figure, we can see a positive linear relationship between systolic blood pressure and increased mortality from ischemic heart disease. And also, there is a linear relationship between stroke mortality and increase in systolic blood pressure. Moreover, the risk of cardiovascular mortality doubles with each rise of 20 millimeter mercury systolic blood pressure and 10 millimeter mercury diastolic pressure, as we can see in this histogram. For example, the rise of blood pressure from 115 systolic over 75 diastolic to 175 systolic over 105 diastolic blood pressure will increase the risk of cardiovascular mortality by 8 times. Target organ damage of brain, heart, kidneys, retina, and the peripheral arteries are serious sequelae of uncontrolled hypertension. Persistent hypertension can put the patient into moderate to high risk categories, like, for example, increased incidence of coronary artery disease, acute coronary syndrome, angina pectoris, myocardial infarction. Also, these patients are vulnerable to develop cerebrovascular complications like aneurysms, dementia, intracerebral hemorrhage, and so on. Hypertensive retinopathy, peripheral arterial disease, and chronic kidney disease are also common complications in patients with neglected hypertension. As regarding classification of blood pressure, the different guidelines provided different recommendations for blood pressure thresholds. The European Society of Hypertension, the European Society of Cardiology Guidelines in 2019 classified blood pressure into optimum, normal, high normal, grade 1 hypertension, grade 2 hypertension, grade 3 hypertension, and isolated systolic blood pressure. On the other hand, the American College of Cardiology, American Heart Association put another classification for blood pressure. They classified blood pressure into normal, pre-hypertension, and hypertension was subclassified into two stages. Stage 1, which is systolic blood pressure equals 140 up to 159 systolic, and between 90 and 99 diastolic. This is stage 1. And the stage 2 is 160 or more, and diastolic 100 or more. Refractory or resistant hypertension is considered when there is a persistent elevation of blood pressure for more than 1 month despite treatment with 3 or more drugs. One of them should be a diuretic. Also, hypertension crisis. We have two types of hypertension crisis: hypertension urgency and hypertension emergency. Hypertension urgency is associated with a diastolic blood pressure of over 120 diastolic with no acute target organ damage. On the other hand, hypertensive emergency is hypertension associated with acute target organ damage, like, for example, acute left ventricular failure, acute renal failure, encephalopathy, and papilledema. Now then, what are the factors involved in the development of primary hypertension? The possible causes. Risk factors for hypertension are either modifiable or non-modifiable. The modifiable risk factors, which can be controlled, such as cigarette smoking, diabetes, dyslipidemia, and obesity, are considered important and common risk factors of hypertension. And we have non-modifiable or fixed risk factors like chronic kidney disease, family history, increased age, male sex. All these are non-modifiable. We can't change these risk factors. How can these risk factors cause hypertension? Diabetes, obesity, dyslipidemia, and smoking will lead to endothelial damage. And this endothelial damage will end with vasoconstriction, atherosclerotic change, and inflammatory process, and all these factors will end with hypertension. Also, primary hypertension may be due to activation of the renin-angiotensin-aldosterone system, RAS system. Also may be secondary to salt sensitivity, which is more common in black people, elderly, and insulin sensitive diabetes, or due to sympathetic nervous system overdrive. So these are three important factors which are involved in the development of primary hypertension. As regarding the RAS system, it plays an important role in regulation of the vascular tone and volume all over the body. Angiotensinogen in the liver is transformed into angiotensin 1 under the effect of renin, and angiotensin 1 is transformed into angiotensin 2 under the effect of angiotensin converting enzyme. And angiotensin 2 is a very potent vasoconstricting substance. Also, it stimulates sympathetic activity. It causes salt and water retention by effect on the renal tubules. It stimulates the suprarenal gland with excess salt and water retention. So drugs like ACE inhibitors, angiotensin converting enzyme inhibitors, will decrease the production of angiotensin 2, and this will result in lowering of blood pressure. Also, angiotensin receptor blockers will compete for angiotensin 2 at the level of receptors, and this will also decreases the blood pressure. The diagnosis of hypertension is established when accurate measurement of blood pressure showed persistent elevation of blood pressure of 140/90 or above. Persistent elevation of blood pressure should be documented at least 3 repeated measurements in 3 office visits over a period of days up to 1 month. Blood pressure is measured either in outpatient clinic or outside the clinic at home or using the ambulatory blood pressure monitoring. The devices used for blood pressure measurement include the automated blood pressure, the mercury manometer, the Android device, and the ambulatory blood pressure monitoring. The automated office blood pressure is preferred method for in-office measurement, while home blood pressure monitoring and ambulatory blood pressure monitoring are preferred for out-of-office method for diagnosis. Measurement should be from the right arm while the patient in the sitting with back supported or while lying flat on his back. Measurements should be under complete basal conditions enumerated here, and the cuff size should match the size of the arm, and you should take systolic blood pressure at the first appearance of sound and diastolic blood pressure at complete disappearance of the sound. Home blood pressure measurement is very important, and it should be measured twice daily in the morning and twice in the evening for 7 days, and take the average of at least 6 days. It is important because it can detect white coat and masked hypertension. It also improves the patient adherence to therapy. Masked hypertension is diagnosed when the office or in-office blood pressure is normal, but outside the office the blood pressure is elevated. So it is normal in office and elevated above normal outside the office. And the vice versa for white coat hypertension, which is elevated during in-office measurement and return normal outside the office. Now then, as regarding the therapeutic strategy that we should go through and to tailor the treatment for every patient separately, the goal of therapeutic strategy is to prevent morbidity and mortality. In fact, it has been reported that for each decrease of 10 millimeter mercury systolic and 5 millimeter mercury diastolic, there will be reduction in heart attacks by 15%, heart failure by 50%, stroke by 38%, and cardiac mortality by 10%. The therapeutic strategy is based on assessment of the global cardiovascular risk profile of each patient individually to diagnose the presence or absence of target organ damage, also to measure the blood pressure accurately and to decide the blood pressure level at the time of diagnosis, and finally to decide which blood pressure target is required for this particular patient. There are preliminary investigations of patients with hypertension that will be required to assess and help to assess the global risk factors for a patient with hypertension. These investigations include urine analysis, blood chemistry, fasting blood glucose and or hemoglobin A1C, to do lipogram and an ECG for each patient with hypertension. How to predict the global cardiovascular risk of a hypertensive patients? There are methods to predict this risk factor. We have the cardiovascular risk charts, the SCORE system, and the 10-year atherosclerotic cardiovascular risk calculator. The cardiovascular risk chart predicts the level of risk at different grades of blood pressure. I'll give you an example of how to read this cardiovascular risk chart. If we have a grade 1 hypertension or a patient with grade 1 hypertension and he has no other risk factors, so his cardiovascular risk is low. On the other hand, if we have a hypertensive patient with the same grade 1 hypertension, but he has multiple risk factors, cardiovascular history of cardiovascular disease, chronic kidney disease, the cardiovascular risk of this patient will be very high. So that management of patient 1 with grade 1 hypertension and no other risk factors will be completely different from the other patient with very high risk, although both of them have grade 1 hypertension. The first one, we can start with lifestyle modification or monotherapy. The second patient who is at very high risk, we should start with combination therapy, 2 drugs, and he should be followed very meticulously on frequent visits. The next method for assessment of cardiovascular risk is SCORE assessment or SCORE system, and it is recommended by the guidelines to predict cardiovascular risk in hypertensive patients who are not already at high risk. This SCORE risk chart includes 5 risk factors: 6, age, systolic blood pressure, total cholesterol, and smoking. Now I'll give you an example of how to use this chart. The cardiovascular risk of this patient, who is 50 years old, male, smoker, with systolic blood pressure of 180, and his total cholesterol is about 300 milligram per deciliter. This patient has a cardiovascular risk of 14%, as we can see. This risk is the same of a 50, 65 year of age of this patient who has no risk factors. He is just hypertensive. So the risk of this patient or his risk age is 65 years. So despite he is 50, but he has more 15 years of age because of the presence of these risk factors. The third method of assessment of cardiovascular risk is the 10-year atherosclerotic cardiovascular risk score, and it includes 10 risk factors. The age, the gender, race, total cholesterol, decreased HDL, systolic blood pressure, diastolic blood pressure, and if this patient received treatment for hypertension or not, the presence or absence of diabetes, and smoking. The second factor which determines our therapeutic strategy is target organ damage. The presence of target organ damage put the patient into high risk or high risk category for therapy. So if a patient comes or hypertensive patient comes with target organ damage, he is considered at high risk to develop cardiovascular complications and cardiac mortality. So for this patient, combination therapy should be started immediately with blood pressure target of 130/80 or less. The third factor which will affect the treatment strategy is the basal blood pressure level at the time of initiation of treatment. For grade 1 hypertension, the initial treatment may be either lifestyle modification for 3 months or monotherapy, while a patient presenting with grade 3 hypertension, immediate combination therapy with frequent follow-up will be the case. The fourth factor which will affect therapeutic strategy is blood pressure target. Unfortunately, different guidelines recommended different blood pressure targets according to the patient's age and the presence or absence of target organ damage and risk factors. And here we can see the goal blood pressure varies from guideline to another. However, still widely accepted, a blood pressure target of less than 140/90 will be used in patients with uncomplicated hypertension, and in cases with complicated hypertension, our target will be less than 130/80. As regarding treatment, all guidelines emphasize the importance of lifestyle modification as a cornerstone treatment of hypertension. These include weight reduction, use of DASH diet, dietary sodium reduction, physical activity, increased physical activity, and moderation of alcohol consumption. The European Society of Cardiology in 2018 recommended 5 major groups of drugs: ACE inhibitors, angiotensin receptor blockers, the ARBs, the calcium channel blockers, the diuretics, whether thiazide diuretics or indapamide, and beta blockers. And the guidelines emphasize that nearly 2/3 of hypertensive patients need 2 drugs as initial therapy, and single pill combination is preferred. And this figure shows that patients' adherence is better with single pill combination therapy than multiple pill therapy. The common combination treatment recommended by all guidelines include the following: ACE or ARB with calcium channel blockers, ACE or ARB with diuretics, calcium channel blockers with diuretics. These are the common combination recommended by the guideline. And this treatment algorithm simplify how to proceed with treatment. Of course, lifestyle modification is the cornerstone treatment for hypertension in addition to pharmacological treatment. We start with single pill dual combination therapy, ACE or ARB with calcium channel blockers or diuretics. If we do not reach the target blood pressure level, we add a third drug, so it will be 3 drugs in step 2, and it is better to use single pill combination as well. And if no response, we consider this patient has resistant hypertension, and we add a 4th drug, which may be spironolactone, aldosterone antagonist. Beta blockers can be used at any of these 3 steps. There are special groups of patients who will need certain drugs. For example, hypertensive patient with heart failure, the preferred drug is either diuretic, beta blockers, or ACE inhibitors. Patients with hypertension and developed myocardial infarction, the preferred antihypertensive therapy will be beta blockers or ACE inhibitors. In pregnant lady, the safe drugs or antihypertensive drugs during the pregnancy include methyldopa, nifedipine, and or labetalol. ACE and ARBs are contraindicated during pregnancy. As regarding secondary hypertension, it is expected in cases with abrupt onset of hypertension, onset of hypertension in young individuals below 25 years of age, or in very elderly patients. It is also expected in those who are not responding to treatment easily, or those with refractory or resistant hypertension, those who will develop episodes of hypertensive crisis. And the common causes of secondary hypertension include renal parenchymal disease, renovascular disease, primary aldosteronism, obstructive sleep apnea, and alcohol-induced hypertension. Uncommon causes like pheochromocytoma, Cushing, hypothyroidism, aortic dissection, congenital adrenal hyperplasia, acromegaly. And before we end, there are 9 points you should remember. First, measure adequately blood pressure levels at 3 to 5 different occasions in and out of office. Assess the overall cardiovascular risk by using the different charts that I have mentioned. Our target to 120 to 129 over 70 to 79 if tolerated in patients with age below 65. Never go less than 120 millimeter mercury to avoid severe hypertension and complications, especially in those who have an underlying coronary artery disease. Change in lifestyle can obviate the need for pharmacotherapy in patients with mild hypertension. RAS blockers, calcium channel blockers, diuretics, and beta blockers are core treatment in uncomplicated hypertension management. Start with single pill combination, except with those who have blood pressure 140/49 and low risk or frail patients. You can use either lifestyle modification or monotherapy. Multiple drugs are often required to reach target level. Reassess your patient with uncontrolled blood pressure every 1 to 2 months. And thank you very much.